Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai, here in New York City. Thank you for joining me for this 295th episode of the podcast. I hope all had a great week and enjoyed last week's episode on the topic of endocarditis. We spoke with Dr. Francesca Sperotto of Boston Children's Hospital about a recent meta-analysis she performed looking at the efficacy of dental prophylaxis for high, medium, and low-risk patients. For those of you interested in this important and interesting topic, I'd recommend you take a listen to last week's episode 294. As I say most weeks, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. This week, we move on to the world of interventional cardiology. The title of the work we'll be reviewing is Right Disc Thrombosis of the new GORE Cardioform ASD occluder. The first author of this work is Omar Oliva, and the senior author, Mario Carminati. And this work comes to us from the Pediatric and Adult Congenital Heart Center, IRCCS Policlinico San Donato, in San Donato, Milan, Italy. At the present time, as I'm recording this, I'm not actually sure if we're going to have a guest. I've tried reaching out to my Italian colleagues and have not yet heard back. So it'll be a little bit of a mystery to see if we actually have a guest, so listen carefully and we'll see. For now, let's move straight on to the article and then a conversation about it. Let me preface this week's review to say that although I generally am very positive about the papers that I'm presenting here, and it can be said that I have been fairly criticized for perhaps my overly fawning comments about some of these papers, a point which I would contest at times. I think no one is going to accuse me of this approach this week, as I think that this paper is honestly not all that great. It's a single-center, retrospective study of something with only 44 subjects, in which something bad happened 3 times. Is this worthy of review? Well, for methodological reasons, for certain, no. However, I do think that it presents an issue that may affect patients undergoing transcatheter ASD closure rarely, and so I'm presenting these data today perhaps just as a cautionary tale, but it's clear that we're going to need a lot more data in the future, which we're likely to get in the near future with the so-called ASSURED study of the GORE ASD device. And so with that proviso, let's go into this brief paper description. The authors begin by basically explaining that transcatheter ASD closure is associated with high success and low complication rates, and has generally been established to be an optimal approach for the patient with the correct hemodynamics and anatomy. They then explain that prior works with prior devices used for ASD closure suggest a rate of thrombus formation of about 1 to 2%, and they review how, if it's on the RA side, this could result in a pulmonary embolism, and if on the left atrial side, potentially stroke. They then describe some of the features of the relatively newer GORE Cardioform ASD occluder, which is made of platinum-filled nitinol wire as the frame, and it's covered with PTFE. As most of you know, the most important or compelling reason that this device is slowly being used more and more commonly is that it's thought to be associated with a markedly lower chance of aortic erosion, which rarely affected the Amplatzer occluders. They mention prior studies suggesting good efficacy and safety, especially in patients who would be considered particularly risky patients for an Amplatzer-related erosion, such as patients who have a large ASD or one with deficient aortic rims. The authors then explain that in the recent past, they've seen some RA thrombi on this device, and given the paucity of data on this particular finding of thrombus on the right atrial disc, the authors felt it important to report this information in this report. They retrospectively reviewed all patients getting a GORE Cardioform ASD device from January of 2020 till September of 2022 at their hospital, and to be included, you had to have an ASD with left-to-right shunting and RV volume overload, and the patient had to have had a GORE device successfully implanted. They review the baseline, procedural, and follow-up information, including clinic visits and echo at 30 days post-op as well as 6 months later, and if available, 1-year follow-up data was also included. The authors review the implantation approach, and for those who are involved in these procedures, I think it'd be fair to say that it's fairly standard, with the team in Italy using transesophageal echo guidance and patients getting cefazolin and also heparin with an ACT goal of 200 seconds or higher, which is perhaps somewhat lower than some centers which set that level at 250 or above, but certainly it's not an unreasonable goal. Patients all received aspirin immediately after the procedure with no loading dose and always started after the procedure. All patients were observed overnight and all had a transthoracic echo before discharge. And on to the results. Okay, there's really not much here, and so again, I wish to be clear in setting expectations. Basically, there were 49 patients in the time period at this center who had an attempt at a GORE device implanted, with a median age of 9 years, with 84% of the patients being less than 18 years, and a median weight of 32 kilos. The retroaortic rim was deficient in the majority, or nearly 60%, by that meaning less than 5 millimeters, and the average balloon sizing ASD diameter was 18 millimeters. 44 patients, or nearly 90%, had a successful GORE implantation, and the remaining needed an alternative device. The authors used standard choice of devices based on the recommendations of the company, but as many who do this know, there's some overlap between devices that are considered appropriate for different size defects, and so some of the choices were in between, and the authors made their choices based on their own personal experience. Basically, they elected to stratify the ultimate 44-patient group into two groups of those bigger than or smaller than 20 millimeters with balloon sizing. And the authors state that the baseline characteristics of age, sex, weight, height, and interatrial septal dimensions were similar between the two groups. However, it's very important to note that there were 35 patients in the group that was less than 20 millimeters and only 9 in the group greater than 20 millimeters. Importantly, and really the entire raison d'etre reason for this work, is that 3 of the 9 patients with defects sizing over 20 millimeters developed an RA thrombus, and all 3 were noted at the inferior portion of the RA disc. And when they performed a univariate analysis, the only predictor for the development of a thrombus was a sizing diameter that was larger than 20 millimeters. Of note, the thrombi seen were seen in 2/3 at 1 month, and in one patient only 6 months later, and all the patients were taking aspirin when this was diagnosed. All had prothrombotic workups as well as cultures and COVID tests, and all tests were negative. In all, the RA disc was bloated, and fluoroscopy obtained in all showed no wireframe fractures in any of these 3 patients. In 2 of the 3 cases, Lovenox was used and resulted in the clots dissolving, and these happened in 37 millimeter devices. But in the 3rd patient, who had the largest, or 48 millimeter device, the patient developed a PE, or pulmonary embolism, and there was what they described as a massive floating thrombus from the device, and the patient went to surgery for removal of the device and thrombus. The authors show photos of the explanted device and show how the RA disc is swollen and bloated, and also a clot that was formed between the PTFE surfaces of the RA disc, and how it was basically hanging out of an RA disc fenestration that is routinely part of the device design. The authors have a cartoon as what is called Central Illustration 1, and they show how in a large device it's possible that the 2 PTFE surfaces of the RA disc have space between them, and that in this virtual space, blood can fill and a large thrombus can develop there. In their discussion, the authors explain that their work demonstrates the highest risk of thrombus formation with this device of all others that have been written so far, and they remind that the GORE approval study only showed thrombus development in a bit under 1% of patients getting this device. They explain that there are 2 intentional fenestrations in the RA disc of this device, and how this can allow filling of blood in the RA disc and bloating. They state, and I quote, "We hypothesized that in such large ASDs, the metallic part of the device might not adhere strictly to the septum, avoiding the 2 PTFE surfaces of the right disc to remain in contact between them. As a result, this mechanism keeps the fenestration open. Devices with a great surface area, such as the 37 mm or 48 mm device, give more chance for the development of retrograde flow in the virtual cavity between the PTFE membranes. The blood stasis inside the discs activates the coagulation cascade, resulting in thrombus formation and giving the typical bloated appearance. The thrombus progresses to the relatively wide fenestration, and the contact with the bloodstream further increases thrombus formation." Again, let me be clear, this is a theory that the authors have. The authors wonder if the issue is that of oversizing, which may make the 2 PTFE discs not oppose one another properly in rare cases. They wonder also if operators should consider using the smaller of two choices when there are two options to close an ASD with this device according to the manufacturer recommendations. While this approach of using the smaller device might allow more residual holes, they wonder if it would reduce the amount of thrombus formation seen in the larger devices in these rare patients in this study. The authors speak about whether double platelet therapy should be considered and suggest that studies have not generally supported this approach. They wonder if peri-procedural loading with aspirin would be useful, and also if patients should have more frequent follow-up looking for this, so that rapid anticoagulation therapy can be started in the setting of the thrombus. They review the many limitations of this work, including its single-center design, the imbalance of numbers of patients above and below 20 millimeter sized defects, the fact that these small numbers make any real statistical analysis nearly useless, and finally that their theory on why this happened in these patients is entirely conjectural, and so of unclear truth. And so they conclude, right disc thrombosis of the GORE cardiac occluder device is a newly described condition in large diameter ASD, and its pathophysiologic development is hypothesized due to the unique GORE features. Oversizing avoidance could be a viable option to reduce thrombosis risk. Therefore, a careful device assessment at short-term follow-up is pivotal to identify this condition and treat it accordingly. Well, once again, I wish to mention that this is not clearly proving anything, as there is no statistical power to draw any conclusions other than that RA disc thrombus is a possibility. Are the author's comments regarding the mechanism for this thrombus development reasonable? Maybe, but we really don't know. Also, it's very important to remember that the initial ASSURED trial did not in any fashion suggest the incidence of thrombus like this, and that study had many more patients. Additionally, the ASSURED continued access trial results are going to be published by Dr. Qureshi from Texas in the coming year, and certainly the abstract presentation of that work did not suggest that this thrombus issue was anywhere near to what it is described in this work. There were some adverse events like arrhythmia and a lot of wire fractures in the larger trial, but there were not clinical sequelae, and this report showing 8 to 9% having thrombi is quite high, and certainly will be something to follow, but probably is somewhat overstating this risk. I also have significant concerns about the recommendation of potentially placing smaller devices to avoid this complication of thrombosis, and wonder if that admonition may result in more device embolizations, which I think most of us would agree would be at least equal to the problem of a thrombus. Thus, I would say that this work is of some importance in highlighting that this can in fact happen, and that there have been rare reports of this with this device. But beyond this, I don't believe we can really draw any conclusions, other than that probably this high incidence in this work is likely not consistent with other studies on this topic. For sure, we need to keep our eyes peeled for the upcoming continuing use trial results, as I am hopeful that maybe we can get Dr. Qureshi to come on the podcast when it comes published and discuss that much larger North American series with him. Until that time, I think we should keep this information in our minds that thrombus can form in this device, be vigilant in looking for it, but I'm not sure I would change my practice. And I also think that the team in Italy might want to consider starting antiplatelet therapy prior to the catheterization, as is more routine in North American centers. Again, I have no idea if that will make any difference, but that would be maybe the only major difference that I noticed in the description of approach in Italy in comparison to what we more routinely do in the United States. Well, as many of you know from the beginning of this podcast episode, I did make a promise to try and see if one of our Italian author colleagues would come on the podcast, but alas, I've received no response. However, I'm happy that I was able to get another expert on this topic to speak with us today in the name of Dr. Barry Love. Dr. Love is the director of the Congenital Heart Catheterization Laboratory here at my own institution, Mount Sinai Hospital in New York City. He is a graduate of the University of Western Ontario Faculty of Medicine and Dentistry for medical school, and he completed his residency in pediatrics at Montreal Children's Hospital. Following that, he performed fellowship in pediatric cardiology at Boston Children's Hospital, and then he completed successive fellowships in both catheterization and electrophysiology at the same institution. Some of you may remember that Barry was on our podcast 4 years ago on podcast number 131, speaking about adverse events, radiation, and reintervention following transcatheter pulmonary valve replacement. It is a delight to have my friend and colleague Barry on the podcast to discuss this topic. Welcome, Barry, to the podcast. I'm here now with Barry Love. Barry, thank you for being a good guy and jumping in at the last minute to be the guest this week on the podcast.
Thank you so much for having me.
Great. And those of you in the audience who are listeners to the podcast, of course, remember Dr. Love was a prior guest on the podcast about 3 years ago, so thank you, Barry, for coming back. So, Barry, this week's paper shows that in 3 of the 9 patients who had an ASD that exceeded 20 millimeters in this Italian series, there was a thrombus seen on the RA disc. And the suggestion from the authors is that this risk for this complication is perhaps higher in patients who get a larger device. As someone who does a very large number of ASD closures, can you comment on why anyone might get a thrombus there, and if it's your belief that the incidence that they report is likely greater than what you've seen clinically? And also, I'm wondering, do you believe that larger devices are likely to rarely be more associated with the risk for clot?
Yeah, so I actually think this is a very important paper. We have noticed that in our own experience that we have thought that there may be thrombus on the right atrial disc in some of these larger devices. I will point out that we have seen and certainly heard about as well, and know that it's reported, thrombus on surgical ASD patch closures.
Right.
Again, I think if you've got a large amount of foreign body in the left atrium with a large surface area in an area that has relatively slow flow, I think you may be at risk for developing thrombus. So it doesn't surprise me if that patch is surgically sewn in or if it's attached to a scaffold of metal as one would put in with a transcatheter occluder. I think that if you need to close a large defect and you're putting a large amount of foreign material in there, you may be at risk for forming thrombus. So I think that that's probably right, just on first principles.
In other words, you're not shocked that a patient would develop a thrombus occasionally.
Correct.
Yeah.
And so, we have thought that we've seen it. Now, the problem with the GORE devices, I say problem, but again, it's just one of the features or one of the things about the GORE devices is that it's a Gore-Tex membrane over, the nitinol frame. And especially when you've got a fair amount of pressure difference between the left atrium and the right atrium, if you close a large ASD, you're going to have some bowing of that material into the right atrium, and they can look somewhat bulbous. And there's this concept of right atrial disc expansion that we saw with a GORE septal occluder that we don't see as much with a GORE ASD occluder because there's actually more metal as a frame, but it still happens in concept with this problem. And I think that sometimes it can look like a thrombus, even if it's just the membrane that's sort of distended a little bit of the right atrium. Mm-hmm. So I think that we may be overestimating a little bit. Interestingly, they describe thrombus only in the right atrium, not in the left atrium, which again would probably go to that appearance of the device more than just the thrombogenicity, because why would it only ever appear in the right atrium and not in the left atrium? And in our experience, we've seen that as well, where we've seen what we thought could be thrombus, but not clear if it's just the device membrane. So interestingly, in my experience, because of that, with the larger devices, certainly with the 44 and the 48 GORE ASD occluders, we have actually been prophylactically putting those patients on NOAC for 6 months.
I see. I mean, Barry, in this case, there was at least one of the cases for sure had an actual thrombus.
Yes.
They actually explanted the device, and they have a nice picture, as you saw, of this ASD, of this thrombus, rather. But you're saying that even though these 3 might have been real thrombi, it can be challenging on echo even to tell whether you're looking at a thrombus or just dilation of the disc itself.
Right. So in the paper, I certainly believe the one where they explanted and they see and they saw the thrombus, and they've got a nice explanation and a nice diagram of why they think that's the case. And I think that's actually probably right, where there's the sort of pop-off valve, if you will, and some of the serum that's being created through the device because of the pressure maybe leaking out. It might have been sort of a nidus for thrombus formation, and I think that's probably right. And I think that clearly was the case in the device that was explanted. In the other 2 that they show, I'm not entirely sure that that's thrombus versus just the membrane of the right atrial disc. Either way, I think that it is something that is reasonable to think about. It's reasonable to be aware of that. And again, now that we have the ability to give NOACs, and again, for adults certainly, and for older teenagers, I think that's reasonable. You're not putting these huge devices anyways into little kids, so I don't think that we typically have that problem. Those children tend to be less thrombogenic in any case. So for young kids, I don't tend to do it. I've only been doing this with older children and adults with large, the 44 and 48.
And the reason you're saying larger children is because you would not close such a large ASD in a small child with a device typically.
Well, you wouldn't be able to put in a device that big.
Right,
and so the devices that we put in may be big for the size of the atrium, but there's still relatively not as much material.
I see. I mean, you and I talked off air that I spoke briefly with Matt Gillespie about this, who is the PI of the Assured trial, and one of his criticisms of this work is that he seems to feel that their data doesn't support this high of a prevalence of this thrombus. It sounds to me like you're on the same page that yes, it could happen, so it's a valuable report just in that response itself, but maybe not as often as is being shown in this work. And in fact, it sounds like you're not even 1,000% certain that all three of those thrombi were actually thrombi in this work.
So I think that's probably right. I would also just point out, though, that there was not a unified algorithm to post-platelet or post-anticoagulation of those patients. You could do whatever you wanted in those patients. And so, for instance, even in the GORE Assured trial, when we started to see what looked like maybe there was some concern about this, we were using NOAC in our adults that had large defects, even in the Assured trial.
I see.
So and other people may have also as well. So again, we just have to be a little bit careful in interpreting that interpretation.
One last question, Barry. We routinely here at Sinai, and I think most American interventionalists will start antiplatelet therapy prior to the actual procedure. In this study, nobody was started prior. All the patients got their first dose, after the procedure on the same day. Do you think that might play some role potentially in this?
It may be. So I would agree that I think that it is reasonable to start aspirin therapy ahead of time, and certainly before the procedure itself. If they're getting it the same day and they haven't been on it beforehand, we will typically give a loading dose, as you know, like a higher dose right before the procedure. And I think I think it probably does matter because, again, although we're giving heparin during the procedure, as that wears off and these sorts of things, I think that may, if you're going to start with with thrombus formation, it may propagate after that. So I do think it's a good idea to start the antiplatelet ahead of time. Interestingly, we typically start aspirin, as you know, ahead of time. But almost certainly, and with these larger devices, we're going to use a second agent, but I typically wait to start that second agent, usually until the next day. A lot of that reason is that if, God forbid, you have the problem of device embolization or something where you're going to need surgery, I would rather that patient not be on clopidogrel or NOAC if they're going to need an urgent surgery, which again is unusual, but I think that's just what we've been doing.
And especially since we don't really have strong data yet to say that it's even necessary, so the last thing you want is a major complication from it in that already bad situation of a complication of the device embolizing.
Exactly.
All right, well, Barry, thank you very much for joining us this week, offering, as always, excellent concepts and thoughts about this. Thank you.
Thank you, Rob.
Well, as is usually the case, Dr. Love was fairly plain-spoken, sharing his views on this paper. Those who know Barry and his work know that he has an extremely large experience in closing atrial septal defects, and so I would take his words seriously, and he clearly does have some concerns about at least the possibility of RA thrombus, not to mention also LA thrombus in large ASD device patients. I have admittedly always had a bit of a negative bias against closing gigantic ASDs in the cath lab, on the general basis that it would seem inadvisable for prosthetic material to constitute 90+% of a patient's atrial septum. But I would be the first to admit that this is not based on any obvious data, just a hunch. And as Dr. Love just noted, it's not clear that having a large surgically placed patch is definitely safer either than a large device. I thought his idea about giving DOACs to patients to be of interest, but again, I think we'll need to see the upcoming Assured trial longer-term results and see what the data suggest on this. There's a lot we know about this topic, but clearly from this week's conversation, there's a fair bit we do not know, And so the story about this has not been fully told, and I look forward to reading more on this topic over the coming few years so that we can make good, data-informed decisions for our ASD patients. I'd once more like to thank Dr. Love for jumping in at the last minute and saving the day by speaking with us this week about ASD closure on the podcast. To conclude this 295th episode of Pediheart Pediatric Cardiology Today, we hear one of the best-known and most widely recorded works of the great composer Richard Strauss, and this song is entitled Morgen, or Tomorrow, and was written in 1894. Singing this lovely love song, which Strauss wrote as a wedding present to his wife Pauline, is the wonderful American soprano Arlene Auger, who was originally from Huntington Beach, California. Ms. Auger was one of the finest lyric sopranos of the 1970s, 80s, into the early 1990s, when she was tragically diagnosed with the glioblastoma, dying after a valiant fight against this cancer in June of 1993. This live performance was made 4 years prior to her passing. Thank you for joining me for this episode of the podcast. I hope all have a good week ahead.